Okay, let's jump into this deep dive. Today, we're looking at a really important document. It's focused on a critical health challenge in India, childhood pneumonia.
Yeah, and it's not just any health issue, is it? The numbers are stark. It's actually the biggest infectious killer of young children there.
The single biggest, yeah. And the source we're digging into is a guidance note for a major national campaign. It's called SAANS, covering 2024 to 2025.
Right, so Yoons. And our plan here, is to really unpack this document for you.
Exactly. We want to get the key insights, understand just how big this problem is, and then really get into the details of the strategy India is using to, well, try and save these young lives.
It's quite a detailed plan. We'll see some heartbreaking statistics, obviously, but also how they're tackling it from like grassroots home visits right up to improving care in hospitals.
So let's start there. The why. Why is pneumonia such a massive focus? I mean, the document doesn't mince words.
No, it calls it the topmost infectious killer among under fives in India. Straight up.
And the contribution to overall child deaths.
It's 17.51%. Nearly 1 in 5 deaths of children under 5.
Wow, 17.5%. That really puts it in perspective. It's not just a cause, it's a huge chunk.
A massive chunk. And you can see why it demands, a focused national response like the SILS campaign.
And this fits into India's wider health goals too, right?
Yeah.
There's the overall under 5 mortality rate target.
Absolutely. So the U5MR, the under 5 mortality rate was 32 per 1,000 live births back in 2020.
Okay.
And the National Health Policy, the one from 2017, set a goal to bring that down to 23 by 2025.
So a significant reduction overall, and pneumonia has its own target within that.
It does, a very specific one. Reduce pneumonia deaths in children to less than 3 per 1,000 live births, also by 2025.
Less than 3 per 1,000, that's ambitious.
It is. And it aligns with existing efforts in some key states, Bihar, MP, Rajasthan, UP, under what's called the IAPD, the Integrated Action Plan for Pneumonia and Diarrhea. But SAANS aims to really accelerate this nationally.
And it's not just about deaths, sadly. The sheer volume of illness is huge too.
Oh, yeah. The document estimates, get this, 30 million episodes of acute respiratory illness or pneumonia every year in young children.
30 million.
30 million. And about 3 million of those are classified as severe. The incidence rate works out to something like 5 episodes per child per year on average.
5 times a year, potentially. That's a lot of illness.
It is. And when you see those numbers, the illness burden and the mortality, becomes really clear why this needs serious prioritization, serious resources.
Which leads us nicely to the strategy itself, the SAANS campaign.
SAANS. It's actually an acronym. Stands for Social Awareness and Action to Neutralize Pneumonia Successfully.
Social Awareness and Action to Neutralize Pneumonia Successfully. Okay. And they have a tagline.
They do, yeah. Pneumonia nahi to bakpan sahi.
Which means?
Roughly, pneumonia no, then childhood correct or healthy. It's quite a positive frame, Focuses on the healthy childhood you gain.
I like that. Okay, so what are the main objectives laid out in the document for SAANS?
Well, it's multi-pronged. First off, making sure the official National Childhood Pneumonia Management Guidelines from 2019 are actually adopted and followed, getting them used in practice.
Right, not just sitting on a shelf. What else?
Big focus on community awareness and mobilization, getting families, communities involved in protection, prevention, knowing the signs, seeking treatment.
Makes sense. Need that buy-in.
And then, crucially, enabling early identification and proper management when a child is suspected of having pneumonia. Catching it early.
And if it's caught, making sure the health facilities can actually handle the cases, especially the severe ones.
Exactly. Strengthening facility-level management. And all of this ultimately is geared towards intensifying action to hit that mortality target we talked about.
Less than 3 per 1,000 by 2025.
That's the goal.
Okay, huge task. So how does the document say they're actually going to do all this? What's the implementation plan look like?
It seems pretty structured. Starts with a prep and launch phase. Organizing meetings at state and district levels, getting detailed plans sorted out.
And a specific launch date.
Yep, plan for World Pneumonia Day, November 12th, 2024.
Okay. And then the core components of actually doing the work.
Big one is capacity building.
Yeah.
Training, lots of training for different healthcare workers.
Who are we talking about?
Medical officers, staff nurses, the community health officers or CHOs, ANMs, and critically, the ASHAs, the frontline community health workers.
Right. And what kind of training?
The document stresses skill-based training and regular refreshers. So it's not just theory.
Practical skills. Like what?
Like how to properly assess a child, count their breathing rate accurately, use a pulse oximeter, know when to give that first dose of antibiotic, real-world stuff they need on the ground.
Got it. And you can't do that without the right supplies.
Exactly. So ensuring availability of essential drugs is key. Amoxicillin is mentioned specifically as the main antibiotic.
Okay.
Also others like gentamicin, ampicillin, and then the equipment.
Like the pulse oximeters you mentioned.
Yes, pulse oximeters for checking oxygen levels. Plus, reliable oxygen sources in facilities, nebulizers for certain treatments, making sure this stuff is actually there when needed, both in facilities and, where appropriate, with frontline workers too.
Crucial for timely care, absolutely. And alongside the treatment side, there's awareness and prevention.
Huge push there, promoting the pneumococcal conjugate vaccine, the PCV.
We'll probably come back to that. It sounds important.
Definitely. And also raising awareness about risk factors, especially air pollution, both indoor, like from cooking fires, and outdoor pollution.
Okay, let's dig into that frontline action a bit more. The home visits, you mentioned ASHAs.
Yes, the AK's accredited social health activists are central, along with other frontline staff like ANMs and CHOs. They're doing the groundwork in the communities.
And their main job in this campaign?
Home visits, specifically to screen children under 5 for the key symptoms: fever, cough, and difficulty breathing. They are like the first line of defense.
And the document actually details how they do that assessment during a visit.
It does, in an annexure. It's quite systematic. They start by checking for general danger signs, really serious indicators. Like if the child can't drink or breastfeed, is vomiting everything, having convulsions, is unusually sleepy or lethargic, making weird sounds when breathing, looks bluish.
Okay, the really alarming signs.
Exactly. Those mean immediate urgent referral. They also ask how long the cough has lasted. More than 14 days is a red flag for referral too.
Then the breathing rate.
Yes, counting the respiratory rate. It's a core part of diagnosing pneumonia. There are specific cutoffs for fast breathing, depending on the child's age. It's faster for babies under 1 year compared to older toddlers.
Right. What about oxygen levels?
If they have a pulse oximeter, and the plan aims to make these more available, they check this BO2. Below 90% is very serious, needs urgent referral. Even 94% usually triggers a referral.
And they look for physical signs, too.
Yes, looking for chest indrawing. That's when the skin between the ribs or below the rib cage gets sucked in during breathing. It shows the child is working really hard to breathe.
And beyond the child's symptoms, they look at the home environment.
Yeah, assessing risk factors. Are they using biomass fuels like wood or dung for cooking? Does anyone smoke inside? Is there waste burning nearby? Poor ventilation.
And they counsel the family on those things.
Yes, provide counseling on how these things increase the risk and suggest behavior changes.
So based on all that danger signs, breathing rate, oxygen, chest indrawing, the ASHA makes a call.
Essentially, yes. They classify the child's condition right there and initiate immediate management before sending them on, if needed. The goal isn't home treatment for serious cases. It's rapid identification and getting them to help fast.
So what are the categories?
Okay, if the child has any danger signs or chest indrawing or that very low oxygen, it's PO2, 90%, it's classified as severe pneumonia or very severe disease.
And the action.
Give the first dose of oral amoxicillin immediately and arrange urgent referral to a health facility. No delay.
Got it. What if it's less severe, maybe just the fast breathing?
If it's only fast breathing with none of those severe signs, it's classified as pneumonia.
And the action then?
Still give the first dose of oral amoxicillin. And still an urgent referral. They don't want to take chances.
Okay. What if it's just a cold?
If it's just a cough or cold, no fast breathing, no danger signs, then it's no pneumonia. Advise home care fluids, rest, and tell the mother to watch for worsening signs. Schedule a follow-up in 5 days, but still refer if that cough drags on past 14 days.
Right. And there's a specific category for very young infants, too.
Yes, infants under 2 months. If they show specific signs of what's called possible serious bacterial infection, it's also first dose of amoxicillin, urgent hospital referral, and advice on keeping the baby warm during transport.
It's incredible the level of assessment and responsibility placed on these frontline workers making those calls in the home.
It really is. It highlights how crucial their role is in that early detection and making sure kids get to the next level of care promptly.
Which brings us to that next level, strengthening the health facilities. What happens when a referred child gets there?
Well, first, they get reassessed by a doctor. Confirm the diagnosis, decide on the right treatment, which might mean admitting the child to the hospital.
And the campaign is working to make sure facilities are ready for that.
Yes, several things mentioned. Mapping out which facilities can actually provide the comprehensive care needed. setting up designated triage areas so the sickest kids get seen first,
Makes sense in a busy clinic.
displaying clear treatment protocols so staff know exactly what to do, and a really big one, ensuring medical oxygen supply.
Oxygen seems critical for severe cases.
Absolutely life-saving. So reliable supply, the right equipment to deliver at nasal prongs, masks, and using those pulse oximeters constantly to monitor oxygen levels and guide the therapy, keeping it above 90%.
And you mentioned something about skills training earlier, skill stations.
Yes, this is interesting. They plan to set up skill stations in districts. These sound like dedicated spaces for hands-on practice.
What kind of equipment would be there?
The document lists things like pediatric mannequins,
Yeah.
practice dummies, nebulizers, oxygen concentrators, pulse oximeters.
Yeah.
It shows they recognize staff need to practice these skills regularly, especially for managing emergencies, not just read about it.
That practical element seems key. Okay, let's shift back to prevention for a moment. You highlighted the PCV vaccine.
Right, the pneumococcal conjugate vaccine. The document calls it one of the most cost-effective tools
Why is it so important?
because the bacterium it targets, Streptococcus pneumonia, or pneumococcus, is the most common cause of severe bacterial pneumonia in kids. So vaccinating against it can prevent a huge chunk of the worst cases.
And it's available through the government program.
Yes, free of charge under India's Universal Immunization Program, the UIP.
What's the schedule for it?
It's a 3-dose schedule. Primary doses at 6 weeks and 14 weeks of age, then a booster dose at 9 months.
So 3 shots in the first year.
Exactly. And the guidance emphasizes ensuring kids get all 3 doses within that first year for full protection. Monitoring PCV coverage is a key metric for the campaign.
And the other prevention piece was air pollution awareness.
Yes, linking back to those risk factors identified in home visits. Actively creating awareness about the dangers of both indoor and outdoor air pollution for young children's lungs. They even mention linking up with climate change programs where possible.
So it connects individual health to broader environmental issues.
Exactly.
Now, getting all this information out there about vaccines, danger signs, air pollution, seeking care, how does the campaign plan to reach people?
A mix of channels, using mass media TV, radio ads, but also digital platforms, WhatsApp, Facebook, Twitter, meeting people where they are online.
And involving local groups.
Very much so. Engaging with Panchayati Raj institutions, local governments, youth groups, community-based organizations, women's self-help groups, also professional bodies like the Indian Academy of Pediatrics, IAP, and Indian Medical Association, IMA, and NGOs.
So a wide network. What about the specific messages for parents and caregivers?
The goal is really to empower them. First, promote the prevention stuff we know works: exclusive breastfeeding for the first 6 months, good complementary feeding after that, full vaccination, hand washing.
The basics, but always important.
Absolutely. Then make them aware of the air pollution risks. Equip them to recognize those early pneumonia signs and understand that they need to seek care immediately. Don't wait.
And tackling misinformation.
Yes, working to dispel myths about pneumonia, trigger behavior change, and really get caregivers to take it seriously and act fast, not just thinking it's a simple cough.
Okay, so a massive, complex effort. How do they track if it's actually making a difference? What's the monitoring plan?
They'll use the Routine Health Management Information System, HMIS, that's already in place, looking specifically at the data on under 5 illness and deaths due to pneumonia.
Analyzing the trends.
Right. Plus, there's supportive supervision, basically.
Yeah.
Program managers going out to the field, seeing how things are working, offering guidance, checking on progress.
Are there specific things they're measuring?
Yes, the document lists examples. Things like number of health workers trained on the new guidelines, number of under 5s assessed by ASAs during home visits, how many were referred.
So tracking the activity.
Exactly. Also, number of houses where risk factors like indoor pollution were found and counseling was given, number of children actually treated for pneumonia at facilities, how many received oxygen therapy.
And prevention metrics.
PCV coverage rates, definitely.
Yeah.
And tracking if those skill stations are actually set up and functional. It's quite operational.
So pulling all of this together from the guidance note, what's the big picture takeaway on the SAS campaign?
I mean, the overwhelming impression is just how comprehensive it is. It's truly multi-level. It's not just focusing on hospitals or just on community workers or just on vaccines. It's trying to link everything together.
Yeah, you see that connection from the ASA doing screening and counseling about smoky kitchens in a village home.
All the way up to ensuring there's piped oxygen and trained staff ready in a district hospital, plus the preventative power of the PCV vaccine being tracked.
And the skill stations, the specific drug availability, it's detailed.
It really underscores the sheer scale of the challenge. Tackling the #1 infectious killer of young kids is no small feat. But it also shows a very determined, highly organized national effort to meet that really ambitious goal.
That less than 3 deaths per thousand target by 2025.
Exactly. Understanding this plan, you really get a sense of the complexity, but also the commitment involved in fighting a major public health battle like this. It's a blueprint, really.
A blueprint for potentially saving so many young lives. It's quite something to see laid out.
It absolutely is.
You know, this deep dive into the SAANS campaign, it really highlights how all these different pieces have to fit together, doesn't it? You've got air quality, what happens inside the home, the skills of the ASHA worker, the equipment in the clinic, the vaccine coverage. It's all connected.
Completely interconnected.
It makes you wonder, though, like looking at this whole complex machine, what part of this multi-pronged approach do you think might be the toughest hurdle to overcome? Or maybe, which single piece is the most absolutely critical linchpin for its success? Something to think about.